Hi, my name is Dr. Wes, and today we're going to discuss ischemic heart disease associated ataxia. IHD rarely causes ataxia directly. The key mechanism is secondary. Cerebral ischemia affecting cerebral and brain stem coordination circuit. Ischemic heart disease, cardiac embolic or low flow state, posterior circulation ischemia, cerebral brainstem pathway injury, and ataxia. Clinical interpretation. Ataxia in vascular cardiac patients is possible posterior circulation stroke. Cerebral symptoms may appear without obvious limb weakness. Main vascular routes, cardioembolism, hypoperfusion from reduced cardiac output, shear atherosclerotic risk factors might be there. Neurological results, dysmetria, broad-based gait, dysarthria, nystagmus, and imbalance. This might be caused by mistimed cerebral output. Cardioembolic mechanism. Myocardial ischemia can create rhythm disturbance in intracardiac thrombus that embolize the posterior circulation vessels that causes the hypoperfusion. IHD myocardial ischemia, left ventricle dysfunction, wall motion abnormality, intracardiac thrombus or embolus, basilar vertebral pica eca SCA occlusion. That is the mechanism how the embolus blocks posterior circulation focal cerebral infarction. Why this produces ataxia? Cerebral infarction impairs motor error correction. Brainstem cerebral pathway injuries disturb vestibular and ocular coordination. Ataxia may occur with vertigo, nausea, dysarthria, and uh, nystagmus. Low flow hypoperfusion mechanism. Severe IHD acute ischemia, reduced cardiac output, decreased cerebral perfusion pressure, uh, vulnerable posterior circulation territories, cerebral hypoxic ischemic injury. Cardiac site, there are few cardiac sites, lower cerebral blood flow, ischemia can abruptly worsen perfusion, atherosclerosis reduces vascular reserves. Brain side, circulation supplies to the uh, cerebral and brainstem become low. Broadline perfusion may unmask neurological deficit. Dizziness and gait ataxia can dominate this presentation. Cellular injury, energy failure impairs gradient, glutamate excitotoxicity, and calcium overload may occur. Neuronal dysfunction produce ataxia. That is the key note uh, for the students and for the physicians. Hypoperfusion-related ataxia is more likely when heart disease, hypotension, arrhythmia, and cerebrovascular stenosis coexist. Cerebral circuit failure produces ataxia, ischemia, Purkinje's output, deep cerebral nucleus signaling causes mistimed motor commands. Posterior circulation, ischemia, Purkinje's firing failure, deep cerebral nuclei output error, and ataxic movement. Clinical signs, broad-based gait, dysmetria, dysarthria, nystagmus. Purkinje's firing failure leads to defective motor learning and timing, and deep cerebral nuclei output error causes poor correlation with the movement, and movement errors might be there. Urgent concerns, cerebral infarction may swell, posterior fossa, complications can serious, and acute ataxia needs stroke evaluation. Integrated mechanism through management map. Trigger IHD, MI, AF, LV dysfunctioning, low flow state of the blood, vascular event, embolus, thrombus, hypoperfusion, neuronal target, cerebellum, cerebellum, brainstem, vestibular or vestibulocerebral pathway, clinical syndrome, acute ataxia, vertigo, dysarthria, and nystagmus are there. MRI and CT or CTA if acute stroke is suspected. Posterior circulation vascular imaging should be there. Cardiac sources ECG, echocardiography for LV thrombus function, assesses MI ischemic cardiomyopathy or embolic risk. Treatment applications, stroke protocol where appropriate, anti-thrombotic strategy might be there, cardiac optimization plus neuro rehabilitation. That is the key message of the slide. IHD associated ataxia is best understood as heart brain vascular mechanism lead to cerebral coordination failure. Thanks and regards. Please like and subscribe our channel. Take care.